All right, so we're gonna. You can tell me if I can skip over any of the initial stuff, okay? And then we can get into the nitty gritty, so, you know about, and some of the terminology. Remember, terminology is important and often very descriptive. Do you need us? No, I'm good, thank you. Sure? Okay.
It's very motherly.
Anyway,
Say less.
so when we talk about axial loading, it means through this vertical axis. Okay, so you'll hear those terms. And so through the skull, thorax, vertebral column, that's axial loading along that vertical axis. Okay, your appendicular, it's not just the appendix when we're talking about skeletal system, it really means the extremities. And so all of this is important in our function, fluidity of movement, etc. Okay, you know that there are two types of mature bones, cortical and cancellous. Cortical is the hard outer coating, and that's what provides the rigidity. Your cancellous or spongy bone is the more porous. It has the blood vessels, blood supply, bone marrow, and the medulla. And there are multiple types of bones. If you don't remember them, you should review them. Okay, as far as talked about the bone marrow, I mentioned it already. It is in the medullary cavity of your long bones. As we age, that bone marrow often becomes replaced with adipose tissue. Okay, so it's that such that erythropoiesis in the bone marrow later in life takes place in more of the flat bones like the sternum, the iliac crest, and even some of the rib bones. So, the blood supply itself, the cortex has those diversion canals, and it has nutrient arteries that penetrate these canals to supply the bone with what it needs. Now, in the spongy bone, it's, you know, the cancellous bone, it actually occurs through diffusion. It's a little bit different. Okay, remember there was a question on the exam in AMS that a lot of you got wrong because it was about, you remember that? How the blood gets there. Okay, and it is important because I will tell you, has Professor G showed you any you know, extremity images where it looks like a crack and it's a straight line, like a lucency right through the cortex? They're nutrient arteries. And if you don't know any better, sometimes you're like, is that a fracture? I mean, I did that. I was like, is that a fracture? No, it's a nutrient artery. Okay. And it has to do with, you know, just knowing your anatomy. Okay. Anything else I wanted to say about this? Bone is living tissue. Right? Bone is living tissue, so it needs nutrients. And when there's damage to it via a fracture or a contusion, okay, it's going to bleed and it's going to have the same inflammatory response as other tissues. Now, the nature of it, it's much more dense. And so from a healing perspective or an infection perspective, it's much more difficult to get tissue levels of antibiotics high enough to kill the pathogens, the bacteria. And so those who have, anybody who's working in ortho, I know a few people, what do they usually have to do if somebody's got a bone infection? Yeah, they take it to the OR. And they often have to debride and irrigate and things like that. And it's actually a surgical procedure. Sometimes they have to amputate. So it does not have this same, it doesn't get the same tissue levels of antibiotics as other tissues do, just because of the nature and density of it and the blood supply. Okay, looking at, again, just the difference between your compact bone and your spongy bone and where your nutrient arteries are. The periosteum is a fibrous covering. It is connective tissue. It's a fibrous covering over the surface of the bones. And so patients will have a periosteal hematoma. Sometimes, anybody here ever played ball or some sport and you get knocked in the shin, right in the anterior shin where there's not much meat, right? And next thing you know, you get this big old goose egg right on the front, right? And how long does it take to go away? A long time, yeah, because it's actually encased in that periosteum. And so physical therapy, they gotta like break it down and massage it, do deep tissue massage and break up that hematoma so it doesn't calcify. Okay, and so, because it collects in this area right underneath between the periosteum and the bone. And it's very hard to absorb or resorb those blood components like you would of tissue groups. Might be, dead horse, you all look either dead or.
Yeah, just dead, absolutely dead.
Okay, we'll try to liven it up.
Let's go home.
Aerobics?
Aerobics. They're just jumping jacks.
Okay. Again, think of bone as living tissue. It's a bunch of connective tissue with cells embedded within it. Okay, that's essentially calcified. It's got calcium, magnesium, phosphorus, other salts, organic compounds that harden it. Okay, that's what gives it its strength. Resists, otherwise we'd be like amoebas, And so, however, again, it's light enough that we can move relatively easily. Okay, as far as the cells go, you have your progenitor cells, which those are your bone stem cells. And they are going to produce osteoblasts. Your osteoblasts are going to build bones. They produce osteocytes. Osteocytes are, they are mature cells that help to maintain all of the matrix and everything that supports the cell. Okay, and then your osteoclasts are your resorb or breakdown cells. Okay, and interestingly, okay, they decrease with estrogen. Osteoclasts decrease when you have plenty of estrogen. So in menopause, when women lose estrogen because of, their degenerating ovaries, okay, and they're not producing nearly as much estrogen, then you're going to have an increase in osteoclasts. Now, is there any doubt why we see osteoporosis now, mostly after menopause in women? Yes, right.
Increase in osteoclasts when there's less estrogen?
Correct. When there's less estrogen. Estrogen decreases osteoclasts. And so decreasing the number, it's going to decrease the breakdown of the bone. As we lose estrogen, the osteoclasts will increase, which will increase the activity and breakdown of bone and release of these calcium salts. So taking a young patient with anorexia. Okay? What happens in anorexia? But say it louder, Ashley.
Will you have like a dysfunction of your HPA axis, so you're not gonna have the estrogen production?
Okay, so it can also lead to it can often lead to amenorrhea, disruption in your HPA stimulation, so decrease in your gonadal stimulation, less estrogen, okay? And so it's going to present a similar, situation. Then add on the fact that they have poor nutritional intake. So they have a decrease in your inorganic calcium and magnesium and things like that. And so you've got a double whammy. All right, cartilage. It's more flexible than the bone, okay? In cartilage, you have fibers that are embedded in a very firm gel. Depending on where it is, some are more dense than others. Okay, and so these are kind of like the cushions, okay, that protect the end plates of the bones. Okay. It tends to be resilient, however, it doesn't heal very well when it's been damaged. There is no real blood supply, so per se, it's more by diffusion. And so it makes it much more difficult and takes longer to repair. Okay, it typically doesn't have nerves. There are three main types: elastic, hyaline, and fiber cartilage. Okay, and you can see where these are mostly located. Okay, so mostly what we talk about in the movable joints is the hyaline cartilage. Hormonal control is important in maintaining bone health. Okay, again, the complex interaction of our thyroid and parathyroid, as well as the kidney with calcitriol, and this balance of calcium in the bloodstream, because that's what really drives all of this. But we need vitamin D, okay? And we need the building blocks, okay? So we need the calcium, the phosphate, and the magnesium in our diet. And so you should review these pathways. And you know that sunlight helps with the conversion of your vitamin D, which is going to increase your higher your vitamin D levels, the more absorption you're going to get from the gut. Okay, the kidney is important in activating vitamin D, and your parathyroids are going to stimulate clasts, okay, to release calcium into the blood to raise the serum calcium levels. And your thyroid is going to stimulate the blasts and build the bone. Okay? And put the calcium and magnesium and phosphate into the bones. Okay, your joints. Okay, I will say it's it's a pet peeve of mine. So don't ever do it. But it's a pet peeve of mine when people, and I'll give you an example, is like my husband had his back, he did something to his back, whatever, and he went to his doctor. God bless Calvert County. Home. You like that, Elizabeth? You know that's how the old timers talk.
Yeah.
That's calls or count. Anyway, he gets to his doctor, and his doctor says, you tore every ligament in your back. You're gonna be out of work for 6 weeks. What kind of, what did you do that you tore every ligament in your back? No, dude, you just have some muscle spasm. Like, I'm looking at him, he's like all, he's shifted and stuff. You could literally see the muscle spasm. So I went to work on him. He, a little bit of deep tissue massage and little ibuprofen. He was back to work in 3 days. You know, ligament attached bone to bone. You sprain ligaments. Tendons attach muscle to bone. You strain, you can't tear a tendon, but you strain muscles and you can strain ligaments. Right? And when you are diagnosing somebody, okay, be specific. I had a year two student, this is when I first started with this program, and I had a student who was getting ready to graduate who wrote up a case, and it was a classic case of like a de Quervain syndrome. It diagnosed it with a wrist sprain. I said, no, don't think so. You've got to be specific, okay? And so a tendonitis is not the same as a sprain, is not the same as a strain. So pay attention to the nuances, and you will be rewarded in your clinical year, okay? Because your preceptors, everybody else, they're looking for little things like that. Right? So tendons, more so muscles to bones, ligaments or bones to bones. Okay, and so if you disrupt the ligament, and it's a major ligament like an MCL or an ACL, you realize, like in the knee, you have 4 ligaments holding your knee together, 4 of these rubber bands, okay, very dense rubber bands that are holding your knee together. If you disrupt one, it can be devastating because they all have a role. Your medial is to prevent dislodgement of the bones medially. Your lateral is to prevent dislodgements of your bones laterally. And then you have your anterior and posterior cruciate cross in the middle, or cruciate cross, and they prevent forward and backward sliding of the knee, of the femur on the tibia. You disrupt one of those, and it's going to put a lot of extra strain on all the other ligaments, not to mention the cartilage and the shear force of that mobility. Okay, so disrupting a ligament can have devastating consequences. Okay, if you disrupt the ligaments in your C-spine, what can happen? Yes, exactly. We're doing charades over here, okay? You can transect the spinal cord, you know, you can have a subluxation of your vertebrae. So very, very different. Tendinous attachments, they're usually, some of them are bigger tendons. Usually, I mean, that is a clinical diagnosis. You can feel them. And guess what? If you have a patella tendon rupture, what's the patient not going to be able to do? Bend the knee. Or flex the knee. Same thing with a quadricep tendon rupture. You can put your hand in there and feel the deficit. And I'll tell you that one time I actually was an expert witness in a legal case, and it involved a PA, and I testified against this PA. And it was in the jail system. And there was an inmate who had injured knee playing basketball out in the courtyard where they get their exercise and everything. And he went to the infirmary, and the PA diagnosed this person with a knee sprain. Okay, gave it some ibuprofen. didn't give him crutches or anything like that, he just said, keep walking or, put an ace strap on it. Okay, week later, the inmate came back, still no better, can't walk on the knee, can't extend the knee. And the documentation was horrible. The documentation was so bad. In my deposition, I was like, I can tell you right now, this PA never put his hands on this patient. Never actually examined me, looked at it. So it looked like there was no specifics, not where anything was. And this dude, this patient ruptured his quadriceps tendon. 3 months later, they finally sent him to a orthopedist. Okay? Clinically, this guy's got a ruptured quadriceps tendon. You can put your hand in it. So what's happened now to the quadriceps muscle? Since it hasn't been attached for 3 months. It atrophied and retracted. Exactly. So then they had to stretch it and, try to reattach it. And it was so tight that it ripped right off.
Hmm.
And then had to have a second surgery. Yeah. Right, it's a clinical diagnosis. Don't forget your Thompson squeeze for the Achilles tendon. I was watching Aaron Rodgers, the first game this last football season. I was like, he ruptured his Achilles tendon. Aaron Rodgers just walked off the field. He went off the field. Like, he ruptured his Achilles tendon. And then it came out. He ruptured his Achilles tendon. But like, you can see it. You can see it. You can see. You can't plan or flex. This is a clinical diagnosis. You use imaging to confirm it, but these are major tendons that can have devastating consequences as well. Okay. As far as your joints go, your articulations, they're listed here. You have solid, you have synovial. There's lots of different types of synovials on the next slide. Your bursa is like a little sac, it's like a little fluid sac. And it's where there's pressure exerted, so in order to prevent friction, okay? And so you have like bursal sacs over like where your acromion process is, you have them on your elbows, you have them on your knees, and wherever there's that kind of potential for friction, that it does prevent that. And then you have your interarticular menisci, which are the more denser hyaline cartilage on the end plates of the bones, okay? And it's supposed to provide smooth, fluid movement. These are your different joint articulations, okay? If you don't remember, there for you to review, it would be helpful. All right, so let's talk about injuries and trauma. Okay, and what happens with these joints. So some general observations, okay? A lot of the injuries and trauma are either athletic injuries, and they can be athletic injuries in non-athletes, okay? That they happen quite often. They probably happen more often than the athletes themselves. The fathers who won, Thanksgiving Day, haven't played sports in, a year, and they go out on Thanksgiving morning and they all get up this big flag football game. And if you're working the ER, it all comes in, all these, and you've got all kinds of injuries. So it can be acute, it can be overuse. And so your acute is usually some type of sudden trauma. And it can be something as simple as planting and rotating. Okay, planting a foot and rotating, you just ruptured your ACL. Okay, and so it doesn't have to necessarily be a contact sport. I've seen some really awful injuries in my career. And two stand out. One was a soccer player, they were playing indoor soccer, anybody here soccer players? Okay, playing a soccer, and we got the report of a dislocated knee, and we're all thinking, okay, it's a dislocated patella, like, no, it was a dislocated knee. The femur and the tibia dislocated.
We saw that. Where though, it wasn't.
So what do you have to worry about?
Everything. Neurovascular.
Neurovascular compromise, exactly. This guy had no pulse in his foot,
Forever.
no pulse in his foot. We had to get him to go on ASAP. The other one was, it was a Sunday night, I'm still remember, don't ask me why I remember these things. But it was a Sunday night and this young woman had come in and she had been riding a horse. And the horse threw her, but her foot got caught in the stirrup. And totally dislocated her talus. So her talus, which is the bone for the ankle mortise where the tibia attaches, was rotated 90 degrees the wrong way. So think about all the ligaments that it disrupted. She had to go to the OR like ASAP. So that, to try to, so that, we didn't compromise blood supply to the bone and develop avascular necrosis. So anyway, it can be some of the, you get some very strange injuries, okay? Always think about your mechanism and what can happen next, okay? Overuse, just like, we talked about earlier in the semester, overuse injuries, just, repetitive, unusual stress, like throwing curveballs, which causes the epicondylitis. You've got tennis elbow, golfer's elbow, and you have and some of your baseball players, and they'll develop the epicondylitis in their elbows. And that's just from excessive stress and rotational force. So we see it more so in the heel, the elbow, knee, now the thumb, like thumb. Gamekeepers, you got it. Okay, ultimately it can lead to tendonitis. So when you have chronic inflammation, sometimes it can lead to other destruction of some of the other structures. So you always have to think about what's underneath and what else is being damaged. Okay, soft tissue injuries. There's a range of those, a contusion versus a hematoma versus a laceration, and the severity of them, is all, it's a matter of the force of the impact, the degree of bleeding, comorbidities, is the patient on blood thinners, and the depth of any kind of laceration. Because if it's deep enough or in specific areas, you have to consider your nerve, tendon injuries, etc. Did I try to tell you about the girl one time? The guy who came in, and he had an open dislocation of his PIP of his finger because this girl got mad at him and kicked him with pointy-toed shoes, busted open his whole joint, and his finger was the other way, and it was completely open. So, compound dislocation. Interesting things. You'll see. So when we talk about joint injuries, okay, get the mechanism. Okay, the patient may tell you, I rolled my ankle. You don't write down patient rolled his ankle. You can use that in your chief complaint, and that's it. Your job as a clinician is to determine, did this patient have an acute inversion injury, eversion injury? Was it a combination, eversion and dorsiflexion, what was the mechanism of injury? And you describe that. Okay, and so most of your joint injuries have to do with those kinds of injuries, whether it's in mechanical overloading or some type of forced stretch or twist. Okay. Talk about strains. Okay, these involve muscles. Sprains involve ligaments. Okay, realize that ligaments attach to bones. Sometimes if they disrupt, you can have an avulsion fracture. You can have the insertion of that ligament where it attached onto the bone. When it pulls off, actually avulse that cortex where it attached. Okay, and that's an avulsion fracture. Okay, the repairs, again, as far as the joints themselves, very, very slow. It takes a long time. And, you know, we need those fibroblasts and some of those chondrocytes to repair. And so sometimes it can take months. Dislocations. Okay. Dislocations specifically refer to the displacement of the bone, the terminal endpoints of the bones comprising the joint. Okay, and they can be partial, which is more of a subluxation, or they can be a complete dislocation. And so keep in mind, there are ligaments and often tendons that are involved in the composition of this joint. And so you have to always assess those components of the joint in addition to the bones. It's not simply the bones themselves. Okay? And so always realize you've got to check neurovascular supply. Loose bodies can happen. These are typically small pieces of cartilage or bone that avulse. We often refer to them as joint lice. And they move around inside the joints. Sometimes they get stuck in the hinge joints. And so people will say, yeah, like I can't extend my knee. There's something sticking or catching it and I can't, or I can't flex it. And so joint lice can happen, especially cartilage. If it peels off or tears and peels off into that hinge joint, it's going to prevent fluid movement. And that can be quite painful. Hey, your shoulder and rotator cuff injuries are especially problematic. But keep in mind your sits muscles all attached with tendons. Okay, and it is a ball and socket kind of joint, but the articulations involve the acromioclavicular, your sternoclavicular, your glenohumeral and your thoracoscapular. And so there's all kinds of joints involved with some of these muscle groups. And so, and tendons as well. So in an acute phase, you know, you're gonna worry about relocating the joint, you're putting the humeral head back into the glenohumeral fossa and reducing that dislocation. Down the road, you need to do an MRI. A week or so later, you do an MRI to look at the tendons and the muscles and see if there's anything else, labrum, that got torn during the episode. Okay. Knee injuries. Again, especially subject to twisting, also compression forces from jumping and landing. You have the two articulating main bones, your femur and your tibia, The fibula articulates with the tibia only, it does not articulate with the femur. Your patella is it's essentially a sesamoid bone that rides over top of the femoral groove and is kind of embedded in that quadriceps and patellar tendon. So they join and at the patella. Now, there's also structures that kind of keep that patella in place. But when like your lateral ranunculum, and when that starts to, if it's too tight, it's gonna offset the tracking of the patella. It can lead to dislocations, most commonly lateral. And then also it can lead to unusual wear and tear of that cartilage if it's riding too far laterally over that lateral femoral condyle and lead to what we call patella condylation. We talked about meniscal injuries. There's lateral and medial. Lateral has the lesser blood supply than the medial. And so it is more difficult to repair and for it to actually heal. Your patellar subluxation and dislocation. People say, yeah, my knee keeps popping out, and they're referring to the little kneecap that slides again, typically laterally. And then over time, a lot of that has to do with either the tightness of the lateral ranunculum, the shallow nature of the femoral groove, or the increased Q angle of the hip especially for females. Okay. And then I talked about chondroplasia, so. All right, hip injuries. Okay, again, ball and socket joint. The blood supply is through the femoral neck. This is an important factor in your hip injuries, and I know in clinical diagnostics, we differentiate, and probably in Clin Med too, differentiated between a femoral neck, a subcapital femoral fracture, femoral neck, intratrochanteric, subtrochanteric. Okay. If the blood supply through the femoral neck is disrupted, we end up doing, it makes a big difference when you call up an orthopedic surgeon on the phone and you say, yeah, I got a patient with a femoral neck fracture versus an intratrochanteric. One gets internal fixation with pins and rods. The other one gets a hip replacement. Okay, if the blood supply to the femoral head is disrupted through femoral neck or subcapital, most of the time they're going to do a hip replacement because you've disrupted that blood supply, and ultimately that whole femoral head is going to die. Your dislocations, which we talked about, and also in clinical diagnostics, can be anterior, posterior, but posterior in the hip is most common. Shoulder, which one's most common? Anterior. Good. Okay. And you got to think that was a heck of a force to disrupt that. Now, those who've had hip replacements already often have weakened muscles because of the approach and the surgery itself, and they are more prone to their dislocations. And it also depends on whether they had a total hip or a subtotal hip. Fractures often you're going to see them more so as patients age, either through insufficiency fractures due to osteopenia or pathologic fractures due to cancer or other metabolic diseases. Okay. And so you always have to be suspicious in your elderly patients with hip fractures. And they say they fell, okay, and the ambulance brings them in, and clearly their legs shortened, externally rotated. You got it. Did the fall come first? Or did the hip pain come first and you fell because you hurt a crack? There's a big difference in what came first in this particular case. All right, any questions on these joints so far? Okay, we'll talk a little bit about back pain. Which is very common, and most of you have probably experienced it from sitting in this classroom in these awful chairs. At least a couple of times since you've started PA school. You know, it's all about, again, it's posture, it's, unusual stress on different ligaments, not supporting your lumbar curvature, the lordosis. And so when you have back injuries, you got to think about all the different structures in the back. You have the set joints, you have vertebral periosteum, you have the ligaments, you have all kinds of paravertebral muscles. You have fascia that's attaching it. You have spinal nerve roots. There's a lot going on back there. Okay, and so a lot of people, as they age and they lose their abdominal muscle support, it puts excess stress on the back muscles to support the torso. And so they will often end up with chronic back pain. Okay, the less physical condition they're in, the more common the back pain is, because they start relying more so on those back muscles as opposed to your other core muscle groups. As far as common etiologies of back pain, most of them are musculoligamentous. So it could be a strain or a sprain. And if it's a sprain, it tends to be more specific. If it's a strain, it can sometimes feel more general, and strains will often result in muscle spasm. Okay. As we age as well, you've got to consider degenerative changes in the discs, as well as, just the weakening of the muscles. And the degeneration of those discs between the vertebrae can put excess strain on the facet joints. Consider herniated discs. And as patients age, even that can happen more easily. They get a bad, pneumonia, they're coughing. Sometimes they can actually, that forceful coughing leads to herniated discs in the back. Can also be, I've heard people who had osteoporosis who had developed compression fractures from severe coughing spells. And then always consider spinal stenosis. Okay, and that is the central canal of the spinal, where the spinal cord and the conus medullaris passes through. You get osteophyte formation and calcification, which narrows that lumen and can compress that conus medullaris. Okay, and so that can lead to significant pain as well. And we talked about herniated discs in clinical diagnostics. Okay, and the difference between, I always call it the jelly donut, but anyway, this kind of walks you through and reminds you of the dermatomes and the distribution of your pain and numbness, as well as motor weakness. Okay, so hitting all the different points as far as sensory, and motor for your different nerve roots. Your lumbar and cervical spine are much more prone to disc herniations than your thoracic spine. Why? Pardon me?
Ribs, keep it safe.
Right, it's the ribs stabilize and has less mobility in the thoracic spine. Okay, your cervical spine is much more prone to all this kind of motion, as well as your lumbar spine. When you do your range of motion, do you really do any thoracic range of motion assessment in your patients? No. It's all C spine and L spine, right? And that motion is what acute changes can lead to disc injuries. All right, looks to me like y'all need to get up and move around and get some blood circulating. So we'll take a quick break versus spinal cord. And with the vertebral column injury, you always have to be concerned about the spinal cord, but not all vertebral column injuries will result from spinal cord injuries. Okay, you have to be concerned. You have to look for it. Okay, and not just primary sometimes, secondary. Okay, so we'll get into that in a second. But when we talk about spinal cord injuries, it truly means that there's damage to one of the components of the cord itself, which is your central nerve, considered the central nervous system. Okay, and some of the most common etiologies, which you will see a ton of in your clinical careers, are motor vehicle crashes. Okay, no, not every patient has, okay, a spinal cord injury, especially when it was I was backing out of a parking spot in the parking lot and somebody hit me, okay, or somebody bumped into me. Probably not gonna happen then. So mechanism of injury becomes really, really important. When you have high speed, high velocity, forceful, impactful injuries, then you have to, that's gonna raise your suspicion level. Falls, often another common cause. Violence, especially gunshot wounds. And then, of course, there's always recreational injuries like diving and things that can happen. Your injury types will range from fractures to dislocations to subluxations. And so your initial, and oftentimes your initial evaluation is going to involve plain films, followed by MRI and or CT, depending on what your suspicion level is. If you're looking for a fracture, which imaging is going to be better? CT. Very good, CT. Right? If it's soft tissue injury, like cord or disc, MRI. Very good. All right, and so anytime you have a subluxation or a dislocation, that's when your suspicion level is going to be increased about the potential for spinal cord injury or transection. Okay. Your mechanisms are there. We've talked about some of the hyperflexion and hyperextension injuries. Might be a good time to review those. There's often rotational injuries as well. And then of course, with like diving or falls, you can have your axial loading injuries. Now, a lot of words on the slide. I apologize. Not my normal style. However, I thought it would be better to keep it as opposed to separating it. So when we talk about acute spinal cord injuries, okay, you can have direct penetrating trauma that is like a gunshot wound that is going to, you know, directly injure the cord, or you can have indirect injury from damage to the spinal column. Well, what do I mean? Okay, remember your bones are vascular. You have blood supply, you have spinal arteries going in this area. If you have an injury, you can damage those spinal arteries. It can bleed. Where is the blood gonna go? Right, it's gonna extravasate into whatever space it's in. And it is a small area. And so you can have cord compression. Okay, from an expanding hematoma. So when we talked about epidural hematomas in the brain and subdural hematomas in the brain, do you remember that? Okay. Well, guess what? Same thing can happen in the spinal cord, in this column itself. And you can have epidural hematomas, or you can have subdural hematomas. And so indirectly, damage to a bone can still lead to cord compression. At that point, it's still a surgical emergency to evacuate that hematoma, that this patient doesn't become para or quadriplegic. Okay. Contusions themselves can lead to swelling, edema in the tissues surrounding. If those pressures get high enough, they can compress your feeder arteries, your nutrient arteries, okay? And that can lead to tissue ischemia and ultimately to infarction. And so, just because it seems to be a benign contusion and nothing's broken, it doesn't mean that bad things still can't happen. When we have, those tend to be more of a delayed progressive neurologic decline. If you have sudden transection of the spinal cord, they're gonna lose complete motor sensory, reflexive, everything below the level of the injury. Okay. And realize that when they lose your sympathetic, because sympathetic, ear to ear, sympathetic control, that's your vasoconstriction. Okay, that's your source of vasoconstriction for your peripheral vessels. It can lead to vasodilation. So all your blood then is going to be in the periphery as opposed to central, which can then complicate matters because now it's going to drop their pressures relatively, and they can have what we call spinal cord shock. So the two types of spinal cord injury are primary, which is at the time of whatever the injury is, and then there's secondary that follows that primary injury. And that primary injury may have nothing to do with the cord itself initially. Okay. Any questions on that? I'm not gonna read all of that to you. Y'all quite capable of reading it. Are there questions on it? Does it make sense to you? What I will say is in that secondary, realize that when you start having the tissue ischemia or the compression of those vascular supplies, okay, you have endothelial damage, it's going to trigger that same series of events, including the release of proteolytic enzymes and other lipolytic enzymes from the cells that are now dying. And that will cause even more swelling because it's going to create this inflammatory milieu that we've talked about before. And keep in mind that your nerves at this point, the myelination, if you have lipolysis, lipolytic enzymes in that area, they're going to destroy that lipophilic myelin sheath. And so it can lead to demyelination. Can lead to necrosis in those neural tissues. We have different classifications, types and classifications of spinal cord injury. I know I introduced this back in the fall. I said I would cover it more in depth here in the spring. So the books, images are all the same. So I got rid of them. Okay, your central cord versus ground cord versus anterior cord syndrome, posterior cord syndrome, conus medullaris, Patho syndromes are all listed out here. Okay, and they're all, most of them are pretty descriptive. Okay, we'll start at the ease, what I consider the easiest ones, which is conus medullaris and your Patho. Okay, and so Patho really refers to the horse's tail. Okay, so it's the actual nerve roots. And so it tends to be asymmetric. However, it can still be relatively symmetric. Tends to be asymmetric, and so they will often present with hyperreflexia, the saddle anesthesia, and loss of sphincter tone, incontinence, as well as paralysis below the level of injury. Okay, and that's usually an injury in the lumbosacral nerve roots from L2 distally, sacrally. And so things that could cause that include disc injuries, spinal stenosis, and even malignancies. And again, not exclusive lists, but that's pretty common. As you move up to the conus medullaris, this is really kind of the terminal endpoint of the spinal cord where it branches out into the Patho. And so this tends to be more symmetric involvement because it's right at the origin of the tail. Okay? And so these patients often will have hyperreflexia, some numbness around the anus, as well as bowel and bladder dysfunction. And so that's where you're usually going to see somewhere around T12, L1, that's where the injury is. Okay, so burst fractures at L1, disc herniations in that region, an acute flexion injury, malignancy can all lead to conus medullaris syndrome. Okay, I'm going to jump back up to anterior cord syndrome. So you think about your anterior cord, that's going to be your ventral cord. Okay. And so where you're going to damage that often is a flexion injury. And in these particular cases, there are some other, including any kind of atherosclerotic disease that extends into the spinal arteries or can disrupt clots into embolic phenomenon from ruptured plaques into those spinal arteries on the anterior cord. Disc herniation can do it. And there have been cases where iatrogenically, when we do open heart surgery and like cabbage procedures, we have to cross clamp the aorta. It can actually disrupt the flow through those spinal arteries to the anterior cord. So these patients will have bilateral motor, light touch, and loss of temperature sensation below the level of the lesion. Think about what your anterior cord does. These are your ventral, or we call it ventral horn. Dorsal horn is on the other side. Okay, that would be your posterior cord syndrome. And so if anterior is often from a flexion injury, your posterior cord is often from a hyperextension injury. Okay, even though it's relatively rare. But there are some other causes listed there. But this is one of the more rare syndromes. And in this case, they will lose bilaterally, light touch, proprioception and vibration, because that's the tract, the cerebellar tracts for those. Central cord, often hyperextension, okay, in patients who have some type of spondylolysis, already have a problem with the alignment of the spine, or an intramedullary tumor or syringomyelia. And so these patients will have distal upper extremity motor function deficits. And then the last one would be Brown-Séquard. And Brown-Séquard is typically from some type of penetrating injury or MS. And so they will have ipsilateral motor function, proprioception and vibration with contralateral pain and temperature loss. So these are your different spinal cord syndromes. Okay, and you've got to think about mechanism, know your anatomy. Okay, what's anterior, what's posterior, what does central do? Okay, and your anatomic locations. Right, so we're going to talk a little bit more about the specifics of fractures. And the process, the pathogenesis of healing. And so, you know, fractures are relatively common, okay, and it's really a fascinating process by which healing occurs. It's a common injury to bones, and it is important from a clinical standpoint to determine where in the bone the injury is, all of the different characteristics of it. Is it angulated? Is it aligned? Is it displaced? Is it, what are all the, characteristics of it? Because ideally we want it to heal, to return the best function possible. And if we don't align it well, or it's offset or displaced or angulated, then you're gonna have deformity, and that's gonna affect function. Other things to consider, again, through your mechanisms of injury are, was it an acute trauma? Is it just stress or fatigue? Or is it pathologic? And so those are all considerations. And you know how to describe your fractures. And it just takes practice, so you'll get some practice in your clinical year. Hopefully you're getting some practice in ClinMed as well. And again, realize that the weakest place in the child is the epiphyseal plate, which we use Salter-Harris classifications for. If it involves the diaphysis of the bone, it's not a Salter-Harris classification. Salter-Harris only for the end plates. Okay. And you know the difference between open, closed fractures, compound fractures, all the different, if it's green sticks, buckle, etc. And so with yes,
Sorry, it's actually one more back. I'm sorry if I missed it. Did you talk about shin splints? Like what's confused with shin splints?
oh, stress fractures, fatigue fractures, they call them stress fractures, often confused with, shin splints. Shin splints is not,
It's not stress fracture?
no.
What is?
So a stress fracture is actually through the bone. And shin splints has to do with, disruption of the continuity of the, periosteum with the bone itself. Okay. All right. Your manifestation, sometimes it's very obvious clinically that your patient has a fracture. Sometimes as soon as you touch them, so visually you can see it. Sometimes when you touch them, you can palpate all the crunching and crepitus. It'll give you the heebie-jeebies. And, you know, just realize that all of these can affect your blood flow and nerve supply distally to the injury, from the injury. Okay, and so there are early complications and late complications. And so your early complications have to do with the fracture fragments themselves. Are they displaced? Are they in a joint? Is it going to, if it's in the joint space, it can affect movement and function down the road. If it's a, let's say it's a rib fracture, a lower right rib fracture, you've always got to worry about lacerating the liver. If it's on the left side and it's a lower rib fracture, you've got to worry about splenic puncture and splenic rupture. You've got to worry about fracture fragments that can sever nerves and or arteries, especially big bones like the femur. Okay, and so not only can they poke out through the skin and be open fractures, but they can cause damage within the body itself just by the nature of the sharp edges and angulation, position, etc. Okay. Additionally, the bleeding that occurs because we have disrupted viable tissue and it's going to bleed, is that bleeding can add to swelling as well as pressures within compartments. There can be damage to nerve fibers, either primarily or even as a result of the pressures and the edema. And in some of your larger bones with big, yellow marrow composition, fat emboli can occur. And so they can actually, these chunks of little globules of fat can get into the bloodstream once they've been disrupted in that medullary cavity and get picked up and embolize and then lead to strokes, pulmonary infarctions, and even coronary infarctions. Okay, so realize that not benign. Okay, and so there are stages of bone healing. I do want you to focus on this. I think it's important, and I think it's important patient information. This is sort of some of the pathophys in this is that, okay, after that bleeding occurs at the site of the injury, it's going to form a hematoma. This fibrin mesh clot, okay, then becomes the framework for calcium deposition and healing, okay, bone regeneration. So you're gonna have a hematoma. It's gonna lead to a fairly large clot in the area. Okay, you will have tissue death. You are going to have macrophages, monocytes, white cells that are gonna come into the area to start helping with the inflammatory response and cleaning up the debris. They will release VGFR, which will create neovascularization. Okay, and it's going to occur peripheral to that clot so that it can then bring in nutrients and more cells to allow the osteoclasts and osteoblasts to, number one, smooth out the edges. So the osteoclasts are gonna break down some of the damaged bones, try to, like, it's sort of like a nip and tuck. Most of you probably don't remember that show, but some of you might. But anyway, they're gonna do a little nip and tuck on this fracture and clean it up so that it now can come together and re-heal. Right? And so those inflammatory cells will do that. And as you get into that reparative phase, you start to see this callus formation. And it's like a big cloud of white around often this larger space than what you initially saw. And so the calcium will then deposit into this fibrin meshwork as this hematoma resolves and and you'll get cartilage formation, which then continues to calcify. And then there's a remodeling phase, because now you got this big cloud out there, and then it's gonna continue to do its nip and tuck thing and trim it down, and all of a sudden, you know, what you see 3 weeks, 5 weeks, 10 weeks down the road, even a year down the road is completely different. And the bones will heal, and it looks amazing. It's an amazing process. Right, your healing time, very, very much dependent on your patient's body habitus, movement, nutrition, comorbidities, you know, blood supply, all of those are going to play a role in how well your patients heal. Little kids, unless there's some other disease, they tend to heal really, really quickly. Why? Because they're already growing and, you know, they heal very fast. Old people's can take a whole lot longer to heal because of blood supply issues, because of nutrients, nutrition, metabolic derangements, etc. Right? Some of your long bones can take a total of 6 months to heal. Stress fractures might take 2 to 4 weeks. If you don't have good stabilization or good alignment, malunion or non-union can occur. And they just don't heal. Okay. So I have a picture here that shows a delayed union. Right, even with an intramedullary rod placed. You can see the callus formation a little bit over here. Right? On this version, but this is after 5 months of putting in an intramedullary rod in a patient. Now, the goal of putting an intramedullary rod in is to align the bone fragments, right? But if they're too far apart, or there's still too much movement, or any of the other patient-specific deficits like nutrition, like overall health, it may not heal. And it may be nothing that the physician did. It's just, this is the patient's own body. So a delayed union is when it doesn't heal within the expected time frame. A non-union is when it just doesn't heal. Okay, period. So that can happen, because they will do serial imaging, and some patients just might take a little longer than others. But stabilization is important, because if it's still moving, y'all learned how to do like assistive devices and like toe touch weight bearing, non-weight bearing, all that good kind of stuff, right? Like crutches, yes. Okay, those are, that's important, and it's important to be able to be specific with your patients, because you don't want them moving this and delaying the healing process. All right, other complications of fractures. Nasty looking pictures, aren't they? Right? Without looking at the word verbiage, tell me what you see. Tell me what you see. Okay, so you think bulla. So what does that mean?
Fluid on the basement membrane.
What does it mean?
Fluid.
Okay. I don't see infections. Anybody see infections? You see pus? You see redness? Maybe a little bit in the lower one. A bulla, why does it form? Period. What happens?
It's stuck between the basement membrane.
Louder?
Fluid gets stuck between the basement membrane.
Right, so there's separation of the epidermis from the basement membrane. Okay, there's separation there. Something is triggering this separation. Okay. And yes, you have different causes like staph, which can easily, get rid of or exude a exfoliative toxin. You have different toxins that can do it. You have, and in this particular case, it's high pressures. Okay, and so fracture blisters are an early sign and warning for compartment syndrome. Okay, tell me what compartment syndrome is. Bye, Jacqueline.
Just too much pressure in the compartment around the bone?
So-
Or, yeah.
So what
around
happens?
the bone.
So what happens?
Ischemia, necrosis.
Why?
Too much pressure for blood to get in, I know.
Too much pressure, yes, and essentially it's gonna compress the blood vessels and the nerves. Okay, so if you have so much edema in the region of your fracture or anywhere distal to it, it's going to, the pressures get so high in those compartments that they will compress the blood vessels. Therefore, you have no blood flow to the surrounding tissues, including up through the dermis, because that's where all of your blood flow comes from, the deeper vessels that then get into your subcutaneous and then your dermal tissue. And those blood vessels get up into those dermal papillae. Okay, if you have no blood flow, your tissue is going to become ischemic. It's not going to have exchange of nutrients, and you will get separation of the epidermis from the basement membrane. Okay, and so we see this in areas where there's less room for expansion. And we see it in areas where there tends to be a lot of dependent edema. Okay, so lower extremities more so than upper extremities, although that doesn't exclude the upper extremities. So what's your mnemonic for any type of injury? How do you treat it? RICE, right? What's the E stand for?
Elevation.
Why do you want to elevate it?
Because it's fluid, they control.
Improve return flow and prevent that peripheral edema and that collection in the periphery. Okay? Complex regional pain syndrome is another complication of fracture. Yeah, Brian.
As far as elevation is concerned, if you're concerned about structure injury, are you worried about that it's flowing back to the other direction, still elevation?
Still elevation. Yeah,
Does that make sense what I'm asking?
Yes.
Like,
uh-huh. Yeah, most likely no. The only thing that, the big place where you have to worry about like that MRI and things like that are the femur and the pelvis and your larger bone marrow masses, as opposed to your, it's like crush injuries typically occur in the like distal extremities. And so, less likely there. Okay. So complex regional pain syndrome used to be called reflex sympathetic dystrophy. Now it's complex regional pain syndrome. And this is kind of a long-term syndrome of chronic pain that seems to be due to, that not treating the acute pain response and having all of those constant inflammatory, chemical messengers and stuff, histamine, et cetera, that doesn't clear up properly. And so it's pain that these patients, even though everything's, the acute injury has healed, they continue to have pain, and it's neurologic pain, and the pain is actually completely out of control to the actual injury itself. And they can also have associated with it what we call vasomotor instability, so that they can have changes in their, they can have blanching effects, they can go like completely white, and it affects their vasculature as well, which is controlled by the nerves. And they can have increased sweating. So it's, not a fun thing to have happen. Okay, and then even with thromboemboli, anytime you have a fracture, whether it's due to, well, anytime you have a fracture, you run the risk of DVT or PE, whether it's direct blood, a clot entering the the bloodstream and, disseminating, embolizing, or it's due to being recumbent and immobile. Because once you start to have, injuries and stasis of flow because of immobility, you're now into Virchow's triad. So just a little bit more in depth on your compartment syndrome, which we've already kind of covered, is that it is those increased pressures, usually due to edema, increased vasomotor and capillary bleeding, combination of the two, as a result of the inflammatory response with the injury and tissue death. And those muscles and nerves within that muscular compartment, within that fascial compartment, will actually, the pressures get so high, they're higher than what's in the bloodstream. So it will compress and put pressure on those nerves as well as the blood vessels, leading to decreased circulation and nerve death. Right? That's one of the main reasons we don't put circumferential casts on injuries very commonly. Sorry, thank you. Okay, and so circumferential casts are not very good because it doesn't allow swelling to occur. Okay, a splint will allow the expansion, allow for some expansion, as long as your dressings aren't too tight. Okay, so I know you all did some splinting, and it is important to have padding. It's important so you don't have direct compression of the skin, leading to tissue necrosis. It's also important to have that ability to expand because of the edema, so that you don't end up in a compartment syndrome. A lot of things can lead to the increased compartment volume, and so keep in mind, gravity is not our friend here. So when you tell patients, when we put a sling on somebody, the goal of the sling is not to have them hanging down like this. How many people you see walking around, they got a sling on and the hand's still hanging down like this? Sorry, like this. Okay, they walk around with their sling like this. Sling needs to be up and elevated. The injury needs to be above the level of the heart. Okay, if it's a lower extremity, you can't walk around like that. But when you limit their mobility, you have to get them moving, but at the same time, they need to prop up on pillows and keep the knee flexed. Arm, if they're sitting down watching TV or something, you prop it up on pillows, get it out of the sling, prop it up on pillows, facilitate that drainage. It's always about fighting gravity and not, allowing gravity to become our worst enemy. Right, your 5 Ps with 4 being late findings. When you start to get paralysis, pulselessness, pallor, and paresthesias, those are the bad 4 Ps. Okay, pain is going to occur with the injury, but it's the last 4, those 4 Ps, that are your ominous signs. You see fracture blisters, you're on the verge of compartment syndrome, and you need to check those pressures. Okay, and these patients may end up requiring a fasciotomy. Okay, fat emboli, mention these as well. These can be life-threatening. Realize that these fat droplets can go anywhere in the body, including the brain, the lungs, the kidneys, whatever. Usually long bone or pelvis fractures. Okay, and so patients can present with signs and symptoms of upkeeping, very, very similar. It's just, it is a fat embolus. Okay, they can present with signs and symptoms of a stroke due to a fat embolus as opposed to a thromboembolus. Okay, and usually that's, if it's gonna occur, it's gonna occur within 12 to 72 hours after the injury. And we support it as best we can. We don't give clot busters, okay, because it's not a clot. It's a fat globule. Okay. Clearly repairing the fracture and immobilizing the joint is going to be your, is the best means of preventing that. Just a couple pictures, which I thought were fascinating. These show fat emboli in the brain. It looks like, it's like peppered. These are all just fat emboli that cause strokes. This one involved the lung, and this was from a femur fracture. Okay, and so it looks like this patient has like almost like ARDS, but that's all. It's essentially, this is all pulmonary infarctions from fat emboli. How are we doing? Good. Okay, hanging in there. We're not going to finish all this today, don't worry. But the next one is really short, relatively short, so we'll finish it next week. All right, we're going to move on to bone infections. And typically called osteomyelitis. And this is typically painful unless you have neurologic deficits. It will lead to debility and deformity. Okay, I already mentioned that it's very difficult to treat because we can't get tissue levels high enough, okay, with the antibiotics, and so it's very difficult to clear osteomyelitis. So these patients often do have to have surgery and long-term, like 6 to 8 weeks of IV antibiotics. Kevin, I know you worked in, ortho and probably saw some of this, right? No, never saw that?
We saw like infected joint replacement a couple times, that's what it.
Yeah, but even with an infected joint replacement, very difficult to eradicate. You have two things working against you there, right? What's the second thing? Right, it's a foreign body, biofilms. And so your foreign body, your prosthesis, has no natural immunity to it. And so it gets covered with biofilm and no immune cells, and it's difficult to eradicate. So what do they end up doing in those cases? IV and replacing it or removing the prosthesis, treating them for long periods of time. Right? And then when they're relatively sure, and this could be 6 months, you think somebody had a hip replacement or a knee replacement and it gets infected and they gotta take it out. Yeah, they're gonna be not able to walk. It's a terrible place to be, and it can last 6 months to a year until they can make sure that the infection has been cleared before they'll even attempt to put another prosthesis in. So much more difficult. Okay, and so there are multiple sources of microorganisms that cause osteomyelitis. Okay, realize that this can be acute, subacute, or chronic. The pathogenesis of it, again, multiple ways that this can occur. It can, when you have like a compound fracture, if you have a compound fracture or open fracture, you've already breached the skin integrity, which means that you come in contact with your skin flora and any external organisms in the environment. So that is a direct penetration type of contamination. If it occurs during a surgical procedure, again, if we don't prep the skin well enough, this can be introduced at the time of surgery. It's direct penetration or contamination. Other ways include bloodstream, hematogenous spread. Okay, and so it may be completely distal, but trust me, if you have a patient who just had a hip replacement done and they're having urinary tract symptoms after having the catheter during the surgery, you know they're going to treat it very aggressively because a urinary tract organism can very easily get into the bloodstream, see that prosthesis, see that joint, and then become an infection. Okay. So bladder is common, or the GU tract in general, the GI tract, even the upper respiratory tract can be sources of organisms. So you think about your normal pathogens and even colonizers that are in these areas. When they do, this isn't bone, but when they do cardiac surgery now, even my neighbor, one of my neighbors had a shoulder replacement done recently. Do you know they delayed her shoulder replacement for 4 months? And she had to have all this dental work done because she had an abscess, in kind of this indolent dental abscess that they had to then do a root canal and all this other kind of stuff and treat before they would even do the shoulder replacement. Okay, because the mouth organisms are commonly get into the bloodstream and cause these more indolent type of chronic osteomyelitis. It can also occur as an extension through an infection site. So, has anybody seen like the Aliceroff cages and, or the cage, have I seen the cages that they use for, stabilization? Those that you have? There, first time I saw one, I was like, I couldn't take my eyes off it. I was just like staring at it like, oh my God, that is the craziest thing. So sometimes when people have fractures or they have like an Elizarov procedure where they'll try to extend the bone. Yeah, it's a metal cage that they put completely around the extremity. And then they have these pins, metal, that go through the skin into the bone to align the bones. You can look it up, you can Google
Like a halo, like for the head.
Yeah.
them. And these pins, there's a whole protocol for keeping these pins
Just like all
clean. Because it's a direct route from the skin into the bone.
It's really crazy. Open book fracture. Tell me.
Pretty fascinating. Pretty fascinating. And people go home with these things and they take care of them themselves. It sounds like a horrible idea, but it's what they do. Yeah, it's pretty fascinating. So anyway, if you have, let's say you have cellulitis, or you have a skin infection, or you have somebody who injected and got an abscess, a subcutaneous abscess, that can now spread through the tissues to the joint. And then you can also have, I wouldn't maybe say skin infections as much as like colonization, like diabetics or venous insufficiency who have these chronic ulcers. And they're colonized with bacteria that they can actually now track to the bone. They may not have an active cellulitis, but they can get into the bone and then cause infection.
We had a patient who was coming in, we've been seeing, he was a diabetic patient, he had like terrible neuropathy, and he had a wound on his big toe that we've been treating. We had seen him every week for 3 months, and it was almost closed. So we were super excited, it was almost closed, he was feeling really good. He went on a short weekend vacation with his wife, and he got in a hot tub.
Oh, Jesus.
And he
People don't think.
he came in the next week, and it looks terrible. And we were like, what happened? It was almost closed. We thought we were tripping. We were like, what is happening right now? And so we asked him, like, what did you do in the last week? And he told us about his trip, told us he got in a hot tub. We immediately like sent him for x-rays and all this stuff. And yeah, it was osteomyelitis. And I think when sent him to the hospital, surgery, all that fun stuff. And I think he had like 3 or 4 different organisms that was in his foot. And I don't know whether or not they ended up having to take it, but we were so close.
I know, it's so frustrating.
It was so
Frustrating.
But yeah, it was great. It was
Yeah.
fun. And he couldn't feel a thing. Like it wasn't painful for him at all. He had no clue how bad it
Also
was.
the neuropathy. Yeah. Horrible stories like that. Horrible stories. So it doesn't have to actually be an infection per se, so much as just a portal of entry. Okay. So the importance of undressing your patient, taking the socks off and the wounds and the bandages and looking at everything. Okay. And so, yeah, guess what your most common organism is? Yes, staphylococcus. It just makes sense. Okay, but yes, if you have patients with other comorbidities and they've had altered normal flora, where E. coli now, they've been treated multiple times with all these antibiotics and stuff, and you know, next thing you know, they're colonized with E. coli, which then can become your infected pathogen. Okay, and yeah, gonorrhea, there's your GU tract, salmonella, GI tract, H flu, respiratory tract. These are some of your common organisms that cause osteomyelitis. And yes, it can be polymicrobial as well. And so these just some pictures of osteomyelitis. And these specifically are due to hematogenous spread. And so it kind of, God bless you, sometimes in hematogenous spread, it will go to the vertebrae through the spinal arteries. And that's what's happening in this particular case. We see it, hematogenous spread occurs more commonly in kids, especially with the rich blood supply in the end plates of the bones, and as the bones are growing. We see it in debilitated or immunosuppressed adults, okay, and IV drug users, people who have substance use disorders, do a lot of skin popping or IV injection, you know, Staph aureus especially, it will cause epidural or epidural abscesses, it will cause discitis, it will cause osteomyelitis. And you've got to think of things like the SIJ and the sternoclavicular joints, especially for some reason in those patients. Okay, so let's see. How do we, you know, it's going to cause pain when you have hematogenously derived osteomyelitis. It will present with pain unless there's a neuropathy. Sometimes they'll have bacteremia, so they might spike a fever. But if they don't have to be febrile at the time. Kelly, was your patient, febrile?
He was like fever.
Yeah, exactly. So you can expect that fever and more systemic symptoms because of the bacteremia. And then anytime they move the site, and again, unless they have neuropathy, it tends to be painful. It can be red or it may not be. It all depends on how superficial or deep the affected area is. Your imaging can be completely normal in early disease. We typically will start with plain films as the least invasive. But often move, if you're really suspicious, you'll move to a bone scan, nuclear bone scan, which involves the injection of, radioactive isotopes. So, that's, kind of your progression there. And then clearly you gotta treat the organism. All right, if it's osteomyelitis due to direct penetration and or contiguous spread, so direct penetration or from an area in proximity to the actual site in the bone that's infected. This kind of walks you through that. Think about staph and strep, some of your gram negatives, especially in your long-term patients, lots of comorbidities. Again, that's where you're gonna really start thinking about your gram negatives. So those pin track infections are common because you're directly in the bone. Sometimes if they set bones like fingers, they call it putting pins in it, but they actually put these wires through the skin and into the bone to keep the bones aligned. And then when it's healed, they remove the wires, but they are through the skin. And so there's a certain protocol with keeping those clean as well. And so gotta encourage that kind of care of those devices. Okay, and realize that when you have this devitalized, the traumatized bone, it's devitalized. You've damaged the blood vessels. You've got this big juicy hematoma there, which is a rich nutrient source for bacteria to multiply. And, yes, you've got some white cells in the area, but the bone itself is very difficult to treat. So once they start reproducing in that nice juicy hematoma, they extravasate into the bone marrow, and then they're going to just thrive in that inner matrix of bone. Okay. And what ends up happening is they start to then Pac-Man and eat, the bacteria will just start to destroy all the healthy tissues, and then the nutrients within the bone, leaving this kind of moth-eaten appearance. So your buzzword for osteomyelitis is moth-eaten. Probably some of you may not have seen what a piece of like cloth looks like after a moth eats it, and it's got like little holes in it. And so that's what the bone looks like, is what they call a moth-eaten appearance. Right? Here's a classic post-operative soft tissue infection that then you've already got it tracked because they've cut and they've opened all these layers up. And if it's in one layer, you have to assume that it's already all the way down because it's been opened. Okay? And so what some of the things that you will see are what we call wound dehiscence, where it won't heal properly. You've got this sinus drainage tract where the pressure from all the purulent debris is just exuding out of the opening. And, you know, you culture it, X-ray it, start your IV antibiotics, and see what you gotta do next. Okay, and then in chronic osteomyelitis, which we see more so in adults, you know, it's usually from not managing the infection properly. Okay, and at that point, they have what we call sequestrum or dead bone because of the damage that is done and the loss of blood supply and just the debris from the bacteria feeding on the bone. Okay. And so this shows a couple of pictures of chronic osteomyelitis. These are, so I'll go to the pin track down here. Okay, and you can see this, like, it looks like there are holes in the bone throughout. And here and on that side. So if you can see that, you can see the little loosened areas throughout the bone. The bone looks like it's been eaten by moths. There's a big hole there. These are your pins that are extending into the bone. You can see that moth-eaten appearance there. And that's just from the bacteria direct penetration into the bone. On an MRI, this is showing dead bone here, where you have this loosened area. Okay. So over here, you see it very loosened, and that is your dead bone from infection. And then there's some changes there. Here, you got a big area of dead bone. And so here as well. Okay. And this is just a picture of your osteomyelitis with vascular insufficiency. So 1 year classic, you know, this could be as well a diabetic ulcer. Okay, but you don't see any evidence of infection around it. There's no purulent debris, but you've got a portal of entrance. Right? And there's some very scaly looking feet. Skin doesn't look so healthy, but you've got this chronic kind of ulceration there. Okay, and that can be due to vascular, can be due to diabetes. Okay, but you see the scaly feet and you see that chronic. Now, if you image that, you can see where, although you don't see any infection superficially, you've got evidence of bone erosion and, changes here where it's very lytic, you lose your, bone integrity. The cortex is gone. So, yeah, wound does not have to be infected. Right, all you have to have is a portal of entry. Yes, Abel.
If you suspect like either chronic or like something like this, do you go straight to the MRI?
No.
Like before, okay.
I do a plain film first.
Is
Okay.
that- Well, when is MRI? Like, why was the last slide using MRI?
Different situation. Completely different situation. I can't tell you the exact situation here. These are plain films. Okay, this one's using the MRI. That's an MRI there. But, you know, this may be later in the progression so that you could actually see this question. You're not gonna see that on a plain film. And so if you see evidence of osteomyelitis, depending, you might progress to an MR or even a nuclear medicine bone scan. But your first line imaging is always gonna be a plain film. Okay, it's quick, it's not invasive, and it can tell you a lot of information. Oftentimes they'll follow it up. This one, are you gonna, this one with the pins, are you gonna put that in an MRI machine? So they go blind and breathe like projectiles. No, we'll do. Depends on the material. All right, and then this just shows some nice clocky looking feet. Or you're gonna see some of the worst feet ever. Interesting. All right. So what you see on the outside is not always what you see on the inside. And look at that, you can actually see the hole here. So, anyway, just showing you what you see on the outside. You look at feet like this toe is obviously inflamed. But there's some really nasty looking funky nails. And, this shows evidence of vascular compromise. But here you've actually got a portal of entry. There's a soft tissue deficit in this person's heel. And then here you can actually see the lytic lesions from the osteomyelitis. Right, and that's where we'll stop for today. Watching, yeah.